To continue with some tips on restraint application, it's essential that we do not place surgical masks or spit hoods on the patient. This was sort of common practice up until recently, even in our own ED. But with concerns about suffocation, patients are already agitated. They're often, in distress. You'll see, their elevated heart rate, elevated respiratory rate, covering their mouth and obstructing their breathing is never a good idea. So, we do run into the behavioral patients who spit, and we need to make sure that as staff we're protecting ourselves from that using face shields rather than putting anything on the patient's face. And then, it's in bold, so important, making sure that a call bell is within the patient's reach at all times. That is essential, and not just within reach, but that they are able to use that. That they have the functional ability to do so. Any questions so far? So your patient's now in restraints, and we need to look at what our requirements are for assessment, monitoring, and documentation. So again, as I've mentioned, only staff who are trained can assess and monitor a patient in restraints, and that's what we're doing with all of you today. So, depending on the type of restraint, there is, a little bit different requirements. A patient in behavioral restraints or in seclusion must have continuous monitoring and documentation every 15 minutes. So, really, that is, typically, here at the hospital anyway, our behavioral restraints are, the net bed, not the net bed, the net restraint with the 4-point locking and seclusion. But really, it could be any restraint that's being used for a behavioral reason. And then, assessments and documentation are required. And this really is the same for, our behavioral and medical surgical restraints. We require hourly assessment, and that's a visual safety check and circulation, sensation, and movement check of restrained extremities. So making sure, there's not too tight and there's adequate blood flow. Every 2 hours, the restraints must be released for a minimum of 15 minutes. And at this point, you really want to see, do we need to continue the restraints at this time? Is the patient safe to have them removed completely and permanently? You want to evaluate range of motion, offer food and fluid, make sure that they are able to go to the bathroom if they need to, and provide skin and oral care. We want to make sure we're preventing any skin breakdown. And then every 4 hours, we want to assess, the patient's behavior. Is the intervention in place still appropriate? What is the, the overall status of the restraint? We need to document that. Is it in place? Is it, and then, documenting the necessity and then the provision of education. So, all patients and their family need to be given written education at the time of written education, but they also need to be given verbal education at the time of the restraint. So this 4-hour assessment really is, again, that time to consider, do we need to continue the restraint, or can we do early release? And I just have a little screenshot here of our iView documentation. So, as I mentioned before, there are a lot of risks and potential injuries associated with restraints. One of the big ones that's in a lot of the literature is positional asphyxia. So this is essentially when the body's position interferes with respiration or ventilation. Basically, the patient can't take an adequate breath due to the positioning of their body. So either they have been placed on their stomach, which is a big no-no, their mouth or nose is obstructed, or maybe their neck is just bent forward really far and it's obstructing their airway. So we want to make sure that, airway's clear, there's no pressure being exerted on their chest or diaphragm. So, for example, if you have a patient in a net restraint, you want to make sure it's not too tight, or a vest, that it's not too tight. And then, your patients who have obesity really are at a greater risk of positional asphyxia, so we want to, take extra care with them. And then also, patients who come in and may have been under the influence of alcohol or other substances, or maybe have a respiratory comorbidity, so maybe have asthma, COPD, or CHF. Maybe even an illness where if they're even lying flat is really going to impede their ability to breathe. So we really need to take all of those things into consideration, making sure that we're monitoring their vital signs frequently, their oxygen levels, and their overall level of consciousness. So really, really important. Does that make sense to everyone? Great. So some signs of positional asphyxia: increased heart rate, increased respiratory rate, increased work of breathing, mental status changes or changes in level of consciousness, and extreme anxiety or apathy. So just some interesting things, facts that I've come across are, agitation can actually be a sign of hypoxia, which for those non-clinical staff is decreased oxygen levels. So you may have a patient that's fighting restraints. Not only does, when they fight restraints, say they're in a net, it's exerting extra pressure on their chest, but they might be doing it because they're fighting to breathe. And then in response, staff are applying increased force, which makes it, to hold them down, which makes it even worse. So we really need to be considering that, and making sure you have clinical staff present to continually assess the patient. And then, sometimes a patient is struggling and then all of a sudden they stop struggling and we think, oh, they're just being compliant now. But it really may be late hypoxia. Their oxygen levels have reached that point where it's impacting their level of consciousness. And, that is, it's a late sign and can be very serious. So, we need to be kind of thinking outside of the box with those signs. So once your patient's in restraints, we're continuing to monitor and assess. When is that point where we can make that decision that a restraint is no longer necessary? So, just some criteria here for release are, patient can make appropriate decisions. They understand why they're in restraints. They can contract for safety. They're not exhibiting aggressive or violent behaviors. They're alert and responsive to verbal command. And then in the case of a medical restraint, they're not attempting to remove a tube or a drain or something like that. So these would all be reasons to release a restraint. The last topic that we're going to talk about is restraint first aid. This is something that we haven't traditionally taught in any of our classes, but is something that is really important, especially for non-clinical staff. I'm going to speak to security because you're here in the room. You guys spend a ton of time with patients who are in restraints, especially in the emergency room, patients who are not only on seclusion but in a net restraint. So, you're really our first line to, evaluate, to assess, to pick up on a lot of these signs and alert the clinician. The nurse should obviously be doing her hourly rounds and if not more frequently, but we want to make sure that you all have the knowledge to recognize some of these signs of distress or injury and respond appropriately. So just some topics here that you may potentially come across with a restrained patient. The first is just wounds and blood exposure. So just really important that you're using gloves, a face mask if there's any chance of splatter, gown if necessary, so that you're not coming into contact with an open wound or any blood or bodily fluids. If you do see that there's an open wound or there's an attempt, a patient has cut themselves or self-mutilated, we want to make sure that we immediately notify clinical staff to assess those injuries. and likely will need physician evaluation. Suffocation or positional asphyxia, which we just talked about, we should immediately release that patient from restraint and get them in a position that will allow for that better respiration. You want to call for an emergency assistance, so call for a nurse. We want that clinical staff, nurse or nurse tech, should be assessing vital signs and responding with interventions to help increase their oxygenation. So that's really important, really, that we get them out of that restraints and into that position initially. Patient may choke on food or drink. You will all have CPR training if you have not had that already before you're off orientation, and we would want to follow the American Heart Guidelines for choking relief, formerly known as the Heimlich maneuver, and call for emergency assistance. Spoke to it a little bit with the wounds and blood exposure, but sometimes patients in seclusion will attempt to strangulate themselves or self-mutilate, even may try to, mutilate themselves with a buckle or, the edge of the bed even when they are in restraint. So, making sure that we remove anything that they are using to self-mutilate. And sometimes we may need some extra help with that because we want to make sure that, we don't put ourselves at risk either as caregivers. And we want to follow, protocol for, blood or wound exposure there to get those, addressed. But really, prevention is key with this, making sure that the patient doesn't have access to any tools that could be used for strangulation or self-mutilation. So this is something, again, I think about like an ED scenario where security is, doing one-to-one or continuous observation. We take away shoelaces and belts and things like that, but we need to think about, shirts and sheets and, patients may bring things in their pocket. We do check them, but sometimes we can miss implements, pens, things like that they may use to hurt themselves, or things that other, friends or family may bring in too. So we always have to be very vigilant about that. Allergic reactions, these vary in severity and have a variety of symptoms. So, the most severe can result in complete airway obstruction. So we want to make sure we're reporting any of these symptoms here to clinical staff. And if there is airway obstruction, that we're starting CPR. Patients in restraints can suffer, a true medical emergency, such as a heart attack or a seizure, stroke or low blood sugar. So here we have some symptoms of those medical emergencies. And really with all of these, we want to make sure that, we're immediately calling for emergency assistance from clinical staff to evaluate the patient. A heart attack can manifest with a variety of symptoms. Seizures, we want to make sure that that we are releasing restraints, calling for emergency assistance, making sure the patient's head is patted, that they're turned on their side in case there's vomiting, and really making sure that that airway is clear. And if there is airway obstruction, that we are initiating CPR or rescue breathing as needed. Stroke, that is, again, can manifest in a variety of ways. Facial drooping, weakness, difficulty speaking, confusion. It's not always black and white, just like, heart attack as well. But we want to report those symptoms immediately to clinical staff as well so that they can, do a thorough assessment. And then low blood sugar. Again, a variety of symptoms from lightheadedness, shakiness, weakness, confusion, unconsciousness. So we want to initiate we want to contact clinical staff immediately so that they can initiate treatment. So really we want to have a good understanding of some of these signs and symptoms that really are different from the patient's normal baseline. And, part of that is good observation, careful monitoring, really knowing our patient, understanding, their typical baseline behavior and recognizing when there's a deviation from that. So that's really just an overview It's a lot of information. We're going to talk a little bit more in detail about the different types of restraints, and we'll revisit a lot of these concepts. But if you do have questions, we have the PCDs listed here, and we want to make sure whenever you are restraining a patient that you're accessing these for all of the